Okay, students, so we're going to talk about Chapter 29, Care of the High-Risk Mother, Newborn, and Family with Special Needs. I'm going to warn you in advance, this chapter is going to jump all over your ATI book. We're going to jump from the beginning chapters that we've already covered in class, all the way back to the new chapters that we've yet to cover in the postpartum and newborn areas of your ATI maternal newborn book. So let's get started. Complications of pregnancy. So the first thing to understand is, what is a high-risk pregnancy? A high-risk pregnancy is one in which life of the mother or infant or their health is jeopardized by some type of underlying concern. Okay. And so we're going to try to figure out how to take care of these people and how to best prevent morbidity and mortality. So let's start with the pregnancy issues that are high risk. So the first one is hyperemesis gravidarum. So hyperemesis gravidarum is discussed in chapter 8 of your book. Chapter 8 of your ATI book talks about medical conditions. And on page 62, it covers hyperemesis gravidarum. Hyperemesis gravidarum is an excessive nausea and vomiting condition, possibly related to really high HCG levels. And this goes on throughout the pregnancy. And it can cause weight loss, dehydration, nutritional deficiencies, electrolyte imbalances, and ketones in the urine. We also see that there's a risk to the baby because the baby might become restricted in its ability to grow. That's intrauterine growth restriction, IUGR. The baby might be small for the gestational age that it's supposed to be. That's SGA. And preterm birth may occur if the condition continues towards the ends of pregnancy. It is more likely for moms that are less than 30 years of age to develop hyperemesis gravidarum. Also, if you have twins or gestational trophoblastic disease, so a molar pregnancy, you may be at increased risk for hyperemesis gravidarum. Psychosocial issues, high levels of stress, hyperthyroid conditions, diabetes, GI issues, and a family history of hyperemesis can cause you to develop hyperemesis as well. When somebody has hyperemesis gravidarum, we see excessive vomiting for prolonged periods of time. They become dehydrated. Their electrolytes are low, so sodium, potassium, chloride are all low. The client also may have weight loss, increased pulse rate, decreased blood pressure due to the decreased volume, right? And their heart is compensating for that. And then poor skin turgor and dry mucous membranes. So we're going to do a urinalysis on that client. We're looking for ketones in the urine and also an elevated specific gravity. Remember, your specific gravity is elevated when you are dehydrated. And ketones are expressed when you are dehydrated and malnourished. And then again, that chemistry, we're going to look at sodium, potassium, and chloride levels. They're all going to be low. And then your liver function tests, your liver enzymes and bilirubin level will be up. Your thyroid test may show hyperthyroidism, and a CBC will show an elevated or high hematocrit. That's because, remember, hematocrit is a measurement of the viscosity of blood, the thickness. So if you are low on volume, your blood is going to be thicker. So it's going to be a higher hematocrit. To take care of a client that has hyperemesis gravidarum, it's important to closely monitor their intake and output, to look at their skin and their mucous membranes for signs of dehydration, to monitor their vital signs closely, and to monitor their weight. The client should be in PO until they stop vomiting. And once they stop vomiting, you can move on to clear liquids, then eventually your bland foods. And then you can advance to small, frequent meals as tolerated. Things like dry toast, crackers, cereal, and then soft foods. Some clients may never be able to tolerate foods. Their hyperemesis gravidarum is just so bad. In that case, we may have to resort to enteral nutrition via a feeding tube or TPN through a central line. The client should also be given IV lactated ringers to keep them hydrated and maybe put on vitamins and supplements like pyroxidine, which is vitamin B6. Additionally, the client may be given antiemetic medications like metoclopramide, Reglan, ondansetron, Zofran, or promethazine, Phenergan. After given an antiemetic and the client's hyperemesis gravidarum resolves, the client may also be put on a corticosteroid so that hyperemesis gravidarum does not come back. Okay. With this client, we also want to consider some nutritional considerations. I've got chapter 4 There's some information about nutrition that I think is pertinent for nausea. It's on page 26. Small amounts frequently, every 2 to 3 hours. Avoid large meals. Avoid alcohol, caffeine, fried, fatty, spicy foods. Do not consume a ton of fluid. Do not take medicines to control nausea without talking to the doctor. But if the doctor approves ginger, like ginger ale, ginger tea, ginger candies, and herbal teas like peppermint tea and raspberry tea might help with the nausea. So I just wanted to work that in there as well. The next thing we're going to be discussing is multifetal pregnancy. And the big thing here is there's a lot of things that could happen with multifetal pregnancy. You're at increased risk for an abruption. You're at increased risk for a prolapsed cord. You're at increased risk for hyperemesis gravidarum. You're at increased risk for spontaneous abortion. Lots of things increase the risk with multifetal pregnancy, or that we see increased risk for those things with multifetal pregnancy, especially like preterm delivery. There's a whole bunch of them. So just keep that in mind when you are thinking about a client. If they are a multifetal pregnancy, they're likely high risk for a variety of reasons. The next thing we're going to talk about is a hydatiform mole. This is a molar pregnancy. In your book, it is considered, or it's worded as a trophoblastic condition of gestation. So that's on page 43 in chapter 6. Gestational trophoblastic disease, that's the same thing. So hydatiform mole and gestational trophoblastic. It is a proliferation and degeneration of trophoblastic villi in the placenta that becomes swollen, fluid-filled, and takes on the appearance of grape-like clusters. This is where the embryo fails to develop beyond what it, into what it should be. And so it is this wild little molar growth. And there's two types of the growth. There's a complete mole and a partial mole. A complete mole is where all genetic material is paternally derived. The ovum has no genetic material, or the material inside the ovum is inactive. And so the mole does not have a fetus, placenta, amniotic fluids, or amniotic membranes or fluid. And there's no placenta to get maternal blood. So we just bleed into the uterine cavity. And so there's a lot of vaginal bleeding that comes from that. There's also a partial mole. That's where the genetic material comes from mom and dad, maternally and paternally. And that normal ovum is fertilized by 2 sperm or 1 sperm, and meiosis did not divide properly. So we've got an abnormal embryonic or fetal situation and fetal blood, but there's severe congenital anomalies present, and it's not compatible with life. So risk factors for molar pregnancy include a previous molar pregnancy, and then young teen moms and moms older than 40. What we see here is the hyperemesis gravidarum. It is a huge sign or symptom of a hydatiform mole and really elevated HCG levels, which is the reason for the nausea. The clients need to be watched for bleeding. Oftentimes it's dark brown, but it can be bright red, but typically it's not. It's darker. The client may become anemic from the blood loss, and we might see preeclampsia in these clients too before 24 weeks gestation. An ultrasound would help us diagnose this, and they would want to go in and do a suction curettage to aspirate and evacuate the molar pregnancy. If the client was Rh negative, we would go ahead and give RhoGAM, that RHD immune globulin. And the client should have a pelvic exam and ultrasound scan after we evacuate the molar pregnancy to verify that we've got all of the components of conception. A serum HCG analysis will be done weekly for 3 weeks to make sure that it's continuing to trend downward. And we'll want to continue to measure that client's fundal height to make sure there's no continued growth. The client may have GI upset and decreased appetite with that nausea and vomiting. So we want to make sure that that's returned their appetite and that their GI system is stable. And we want to make sure that their blood pressure has returned to baseline if they developed preeclampsia. Any clots or tissue that the client passes need to be saved for evaluation, and the client may require a tremendous amount of emotional support while going through a molar pregnancy because it is a loss. Sending them to a support group may be a good idea, and then the client should be using a reliable contraception other than an IUD following a molar pregnancy. Okay, the next thing we're going to talk about is an ectopic pregnancy. This is also covered in chapter 6 on page 42. An ectopic pregnancy is the abnormal implantation of a fertilized ovum outside of the uterine cavity, usually in the fallopian tube. And what can happen is, as that pregnancy begins to divide, it can cause that tube to pop open and rupture, and then you could potentially hemorrhage out, and it could be fatal. It is the second most common cause of bleeding in early pregnancy, and it's a leading cause of infertility. Things like having STIs or undergoing assisted reproductive technology or having surgery on your tubes or having a intrauterine contraceptive device like an IUD could put you at risk for an ectopic pregnancy. Ectopic pregnancy is very specific to unilateral stabbing pain because you're going to feel it on one side or the other where it's at in that fallopian tube. It's going to be very tender. Additionally, there will be a delayed period, scant dark red or brown vaginal spotting, potentially referred shoulder pain. So that's because if there was bleeding into the abdomen, you would feel the pressure of that up in the shoulder. As it presses on that phrenic nerve and irritates it. And then there may be signs of hemorrhage and shock if it's really severe and we've ruptured, like hypotension, low blood pressure, tachycardia, a high heart rate, pallor, dizziness because of the loss of blood. Levels of progesterone and HCG will rise to let us know that there is a pregnancy, and there are levels of that which are indicative of ectopic pregnancy. We would diagnose it with a transvaginal ultrasound, and then we would want to rapidly treat the condition. So we want to preserve the tube if we can and prevent it from rupturing. So we can give a medication called methotrexate. Methotrexate is a DMARD, a disease-modifying anti-rheumatic drug that helps to basically dissolve the pregnancy and keep it from continuing to divide and get bigger. When giving methotrexate, clients cannot take vitamins with folic acid in them because it could cause toxicity with that drug, and they become extremely photosensitive. So it's important to practice photosensitivity safety practices like, wearing sunscreen and protective clothing and a wide brimmed hat and things like that. The client may need to have a salpingectomy if the fallopian tube is not ruptured, or the removal of part of the tube. Okay. Excuse me, a salpingostomy to salvage if it's not ruptured, and a salpingectomy to remove it if it has ruptured. We'll want to replace their fluids, help them maintain a good electrolyte balance, educate and support the client, give those meds as prescribed, help them get ready for surgery, provide emotional support, refer them out again to a pregnancy loss group, and continue to monitor their studies like CBC, their liver function, their HCG and progesterone levels. The next thing that we're going to talk about is a spontaneous abortion. Now, remember, the word spontaneous abortion means miscarriage. This occurs when a pregnancy ends as a result of a natural cause before 20 weeks gestation, if the fetus weighs less than 500 grams. So there are different types of spontaneous abortion: threatened, inevitable, incomplete, complete, and missed. So we see spontaneous abortion happen most commonly there in that first trimester, but again, anytime before 20 weeks. A threatened miscarriage is a miscarriage that, we may have lost, but we didn't. So we almost lost the pregnancy, but we didn't. So there may be some mild cramps, some slight spotting, but there's no passage of tissue and the cervix never dilates. An inevitable miscarriage is going to happen no matter what, right? The cramps can be mild to severe with moderate bleeding, and usually the cervix is dilated for that one. An incomplete miscarriage, they usually have extreme cramps, severe cramps, and heavy, profuse bleeding with passage of tissue, and the cervix is dilated. And then there's continued retention of the products of conception. And so we have to go in and clear that out. There's also a complete miscarriage with mild cramping, minimal bleeding, the tissue is passed, and the cervix closes. That is all said and done. It's finished. A missed miscarriage is where you don't even know you had a miscarriage. It may have just felt like a regular period, or maybe you spotted. So there's not usually any cramps or any bleeding beyond a regular period. No tissue is passed, and the cervix remains closed, or it's closed after the passage of the products of conception. A miscarriage may remain inside of the uterus and go septic, which may be, you may exhibit cramps and have a stinky or malodorous discharge with bleeding or without bleeding, with passage of tissue or without passage of tissue, and the cervix usually is dilated. Okay. So, with a miscarriage, we expect to see, you know, abdominal cramping in general, a rupture of membranes if it's, we've gotten that far, a dilation of the cervix, a fever, and then with hemorrhage, we may see low blood pressure and high heart rate, so hypotension and tachycardia. Things that put us at risk for a miscarriage would be chromosomal abnormalities. In fact, 25% of spontaneous abortions are caused by chromosomal abnormalities. Maternal illness, like type 1 diabetes, mom being a little bit older, so 35 years or older, a premature cervical dilation, chronic infections of mom not eating or drinking enough, trauma or injury to the abdomen, anomalies in the fetus or the placenta, mom's substance use, or antiphospholipid syndrome. We would obviously diagnose this with an ultrasound and examination of the cervix, and we would treat it with a dilation and curettage, a DNC, to dilate and scrape the uterine walls to take all the contents out if there's an inevitable or incomplete abortion. And then additionally, we may need to do a dilation and evacuation, which is a little bit more involved to completely evacuate the uterine contents for an incomplete abortion. We may also give prostaglandins and oxytocin to augment or induce contractions to help expel the products of conception, and the client will likely receive pain medication for this. We would want to check the hemoglobin and hematocrit on our client to see if we've got a drop and the client's becoming anemic. We would also want to check their clotting factors because they could develop disseminated intravascular coagulopathy, DIC, as a complication of retained products of conception. So that's where we use all of our clotting factors to clot up, and then we have no more and we begin to bleed out. We want to track the white blood cell count to make sure we haven't developed an infection, and the human chorionic gonadotropin levels, the HCG levels, to show that we are pregnant, and then they'll trend down with the miscarriage. So we want to obviously confirm that there was a pregnancy with a pregnancy test, observe the color and amount of bleeding, put the client on bed rest, avoid any kind of vaginal exam, get that ultrasound done, and then give medicines as prescribed. Assist with the termination of the pregnancy if needed, like a DNC, a DNE, or prostaglandins. And it's really important to use the word miscarriage when talking to clients and not the word abortion, because when they think abortion, most clients are thinking of an elective abortion. And most of the time, they really wanted this pregnancy, or at least have come to terms with their pregnancy and are sad to have lost it. So using the word miscarriage helps prevent hurt feelings. We need to provide the client with lots of education and emotional support and refer them out to a pregnancy loss support group. If the client was Rh negative, it's important, just like with the ectopic pregnancy, to go ahead and give the RhoGAM, the Rho-D immune globulin. And then again, we may be giving analgesics and sedatives to help the client. The client is to avoid any tub baths, sexual intercourse, or placing anything in the vagina for 2 weeks following the miscarriage. And it's important to talk about their grief and their loss and kind of try to process through that before getting pregnant again. And they may experience a small amount of discharge for the next couple of weeks. If they develop heavy, bright red vaginal bleeding, an elevated temperature, or foul smelling discharge, they really need to let the doctor know. And they should be taking their antibiotics in the meantime. The last thing here on this high risk situation of pregnancy is an incompetent cervix. So this is actually covered under complications. I apologize. It is not. It is back in the medical conditions. So chapter 8, page 61, cervical insufficiency. That's what we're talking about with an incompetent cervix. It's a premature cervical dilation. So this happens where products of conception are expelled through the cervix and vagina because the cervix is thinning and shortening and dilating. So if there's cervical trauma, like previous cervical tears, excessive dilatations, if there was a curettage completed, or if there was any surgery on the cervix, that could cause cervical insufficiency or an incompetent cervix. Additionally, having really short labors, having pregnancy losses, having advanced cervical dilation earlier in pregnancy can put us at risk factors, or put us at risk. It is a risk factor. Any intrauterine exposure to diethylstilbestrol, during the pregnancy could put this client at risk for an incompetent cervix. And then if there is any structural defect of the uterus or cervix, that may cause the cervix to be incompetent as well. The client may feel an urge to push or have some pelvic pressure. There also may be some pink stained vaginal discharge or bleeding, a possible gush of fluid, which is your rupture of the membranes, and then the client may feel uterine contractions with expulsion of the fetus. Something we can do to help treat this is what's called a cerclage, and that's a stitching together of the cervix. We can put that cerclage in with a single pregnancy. At 12 to 14 weeks gestation, but we do need to go in and take it out at 36 to 38 weeks so that we could deliver the baby. We would want to monitor the client for uterine contractions, rupture of the membranes, and any signs or symptoms of infection after placing the cerclage. We would diagnose an incompetent cervix or cervical insufficiency using an ultrasound. And we would want to monitor the client's vaginal discharge, the reports of pressure and contractions, and their vital signs. Also, before the client goes home, we want to make sure that they know to continue restricting activity or maintaining bed rest, to encourage hydration, because hydration equals a relaxed uterus. If you're dehydrated, you may have contractions. The client should not be having sexual intercourse and should monitor for any cervical or uterine changes and let the doctor know if they experience anything. And then ultimately, because of the bleeding, the client may experience iron deficiency anemia. So, talking to them about managing that with iron supplements may be necessary. So, that's all 6 of these high risk situations. Now, we're going to move into the bleeding disorders of pregnancy. Bleeding disorders are covered extensively in Chapter 6. And of course, we've already hit some of those: spontaneous abortion, ectopic pregnancy, gestational trophoblastic disease. So, we're going to pick up at placental previa, which is on page 44. Placenta previa, PP, is painless, painless bleeding. It occurs when the placenta abnormally implants over top of the cervical os instead of at the top of the uterus in the fundus. And so it can be one of 3 different types. It could be a complete or total. It could be an incomplete or partial. It could be a marginal or low-lying placental implantation. But regardless, as the cervix starts to dilate, those vessels on the maternal side of the placenta are now exposed and they're bleeding into the vagina. So this is not something we can deliver that is compatible with the vaginal delivery. We have to have a cesarean section for placenta previa. Risk factors is having a placenta previa previously, having any type of uterine scarring. A mom greater than 35 years of age is more likely to have placenta previa. Multifetal gestation, so that's twins or more, multiple gestation, so multiple pregnancies, and smoking put you at increased risk for placenta previa. Again, that bleeding is painless and bright red. The uterus is soft and relaxed and it's non-tender, so touching it doesn't hurt. Um, we also see that the client's fundal height is usually higher than expected, and that's because they're bleeding into that uterus. That baby is usually breech, oblique, or in a transverse position instead of a lateral position, a cephalic presentation. The fetal heart rate is actually usually okay. So it's a reassuring fetal heart rate with placenta previa until it's not. So we do need to intervene and do something about it. But ultimately, babies seem to tolerate at least the beginning of placenta previa pretty well. And mom's vital signs are typically within normal limits. Now, there may be decreasing urinary output, but that's usually later. We would diagnose this with an ultrasound to see where the placenta is, and then we would monitor the baby to make sure that everything is okay. We would continue to monitor mom for bleeding, leaking, or contractions and measure that fundal height to make sure it's not growing. We would not want to perform a vaginal exam on this client because that could make the bleeding worse. And we want to go ahead and administer IV fluids, blood products if prescribed, and any medications that have been prescribed. We may have a prescription to give mom a corticosteroid like betamethasone that's subcutaneously administered in the thigh tissue to help promote fetal lung maturation, especially if we're planning on taking this baby early to prevent further complications with the placenta previa. We should always have oxygen equipment available in case the baby goes into distress. Mom should be on bed rest and not put anything into the vagina if she's been diagnosed with placenta previa. The next bleeding disorder is abruptio placentae or an abruption, a placental abruption. It's the premature separation of the placenta from the uterus, which can be partial or complete. That means that the placenta is peeling off of the inside of the uterus. And this happens after 20 weeks gestation, usually in the third trimester. Unfortunately, this is incredibly deadly for both mom and baby, and it could put it could put mom into disseminated intravascular coagulopathy or DIC, like we talked about before, where mom uses all of her clotting factors up, trying to clot off these placental vessels, and then begins to bleed profusely from every orifice. Risk factors include mom having really high blood pressure. It's like hooking up a pressure washer to the inside of the placenta. It's just going to blow it off the inside of the uterus. Blunt trauma, like getting in a motor vehicle crash, being assaulted, right? Falling on her stomach, things like that. Cocaine use also vasoconstricts the vessels of the placenta, which can cause it to peel off. And cigarette smoking is also dangerous and a risk factor for abruptio placentae. If the client has a premature rupture of membranes or multifetal pregnancy, those are also risk factors. Now, what makes abruptio placentae different than placental previa is placenta previa, again, is just a covering of the cervix with the placenta. Abruptio placentae is where the implanted placenta is now peeling off of the wall. So it's entirely detaching from the uterus. Doesn't matter where it's really implanted. And this is incredibly painful. So that's the difference there. Placenta previa is painless. Abruptio placentae is painful. And that bleeding is usually dark red bleeding. The belly is usually pretty firm. The uterus is extremely firm and board-like, and extremely tender as well. It's super painful. The client may be having contractions with hypertonicity, which means like extreme tone, so super contracted and not letting up. The baby is going to be in distress. That's another difference between placenta previa and abruptio placentae, is that the baby is in distress with placenta abruption, so abruptio placentae. Additionally, mom may be having symptoms of hypovolemic shock, like low blood pressure, high heart rate, etc. Mom's hemoglobin and hematocrit will likely be decreased, as will her coagulation factors. We may see symptoms and signs of disseminated intravascular coagulation. We also can do the Kleinhauer-Betke test to see if fetal blood has made it into maternal circulation. And we want to type mom and cross her for possible blood transfusion because of the amount of blood that she may lose during this abruption. We would diagnose this with an ultrasound, and we want to do a BPP to make sure baby was happy and healthy. We would palpate the uterus for tenderness and tone. We would monitor that fundal height and watch baby's heart rate. And then we have to get this baby out. That is the only way to manage or treat abruptio placentae. So we'd assist with administering her fluids, her blood products, her medicines. We'd give her oxygen, 8 to 10 liters, and a face mask. We would watch her vital signs, and we would assist with monitoring the baby continuously. We would monitor mom's urinary output and her fluid balance. We would emotionally support her, and then we would prepare for delivery, however we're choosing to deliver this baby, and it would likely be a cesarean section at this point. We talked a lot about disseminated intravascular coagulation already, so I'm going to kind of skip past that one. The next disorder is postpartum hemorrhage. So remember, postpartum hemorrhage is most often caused by atony or subinvolution of the uterus. So the uterus not contracting down like it's supposed to allow uh, the uterus to return to its normal space. Postpartum hemorrhage is considered to occur if the client loses more than 500 milliliters of blood after a vaginal birth or more than 1,000 milliliters of blood after a C-section. We see hypovolemic shock and anemia with postpartum hemorrhage, and it's really important that we quantify or we measure with a scale the amount of blood that's lost so we can get an exact number. The client who doesn't have a nice, firm, toned uterus may potentially develop a postpartum hemorrhage. Those with overdistended uteruses from things like multiple pregnancies or multiple babies inside of their belly, prolonged labor, somebody who received oxytocin, a person who has had a ruptured uterus or complications during their pregnancy, like placenta previa or abruption, person who's had a precipitous or very quick delivery, a client that received mag sulfate during labor or developed a laceration or hematoma during delivery, a client that had an inversion of the uterus or subinvolution of the uterus, And then lastly, a client with coagulopathies like DIC or a client with retained placental fragments inside of their uterus are at increased risk for postpartum hemorrhage. We see an increase or change in that lochial pattern, large clots, lots of bleeding. The uterus is boggy, BOGGY, so hypotonic. The peripad is saturated in 15 minutes or less. There's constant oozing, trickling, or a frank flow of bright red blood from the vagina. Mom's heart rate is up. Her blood pressure is down. She is pale. She is cold and clammy. She is oliguric, putting out very little urine. Her hemoglobin and hematocrit will likely be decreased. We would want to go ahead and get a blood type on her because she will likely need transfused. It's important that we weigh all blood saturated items and clots. We need to get an exact measurement. And then if we feel that mom's uterus is boggy, the first thing we need to do is continue to firmly massage the fundus of the uterus. We also need to monitor mom's vital signs, monitor for a source of the bleeding and see if we can stop it. And then monitor the lochia for the color, quantity, and clots. See if there's a laceration, an episiotomy site, or a hematoma that is the cause of the bleeding. Additionally, it's important to palpate the bladder for distension. If the uterus is shifted left or right, it's likely that the bladder is full. So we want to make sure the bladder is emptied so that the uterus is not displaced and can really clamp down effectively as it contracts. So we'll go ahead and put in a urinary catheter. We want to track her eyes and nose pretty carefully to make sure that she doesn't have decreased kidney function as a result of hypovolemic shock. But we also want to see how much she's putting out total. We'll have IV fluids going. We'll likely give volume expanders like albumin and then packed red blood cells or fresh frozen plasma. Mom will be getting oxygen in a non-rebreather face mask, 10 to 12 liters of oxygen, and we'll be monitoring her oxygen saturation. We'll go ahead and lift her legs up so that blood flow goes to the heart, the lungs, the kidneys, the brain, the most important organs. If mom is experiencing a postpartum hemorrhage, we may administer a variety of medications. Those medications include oxytocin, which is a uterine stimulant that causes contractions. It's very important that we check the blood pressure prior to giving oxytocin, and we continue to monitor her tone and bleeding. We may also give methylorgonavin, which is Methergin. It is also a uterine stimulant that helps to control postpartum hemorrhage. It'll require us to continue to monitor her tone and her bleeding, but clients who have hypertension or cardiovascular disease cannot have methylorgonavin. We also need to watch for the adverse reactions like high blood pressure, nausea, vomiting, and headache. Another medication that might be given is misoprostol. It is a uterine stimulant. It's Cytotec. It helps to control postpartum hemorrhage, and we need to continue to monitor tone and bleeding. A medication we may give as well is carboprostomethamine. This is Hemabate. It is a uterine stimulant that controls postpartum hemorrhage. We would want to continue to monitor tone and bleeding and monitor for adverse reactions like fever, chills, headache, nausea, vomiting, diarrhea, and high blood pressure. Additionally, clients who are asthmatic cannot receive carboprost. And for misoprostol, clients that are asthmatic or have hypertension should also probably not receive misoprostol. We also may give a transaminase acid. It's an antifibrinolytic, so it works to help improve blood clotting. So we'd want to give this to a client who experienced postpartum hemorrhage within 3 hours of birth to help them clot up and to manage their vaginal bleeding. The client needs to limit physical activity after a postpartum hemorrhage to conserve their strength and help to increase their iron and protein intake. Um, or we would want to work to increase their iron and protein intake. And they may need to take iron with vitamin C to enhance its absorption. So remember, we always give like iron with like orange juice, for example. Okay, that's a postpartum hemorrhage. I'm going to pause here and kind of break up this lecture. We'll talk about the gestational hypertension conditions in the second part of this lecture.